Hello viewers, I'm Dr. A. Arif Yezdani, Professor and Director in the Department of Orthodontics and Dentofacial Orthopedics. Welcome to the series on removable appliances in orthodontics. In part 1, I had dealt with the retentive components as also the springs, which is the active component of the removable appliance. The other active components, namely the labial bows, screws, as also the bite planes, shall be dealt in this episode, which is part 2 of removable appliances. So dear viewers, labial bows are an important component of the removable orthodontic appliance because these are the ones which gives the force to tip the proclined teeth palatally. So the labial bows are different types. We have the short and the long labial bow, which is made up of 0.7 mm stainless steel wire. We have the split labial bow, which is made up of 0.7 mm stainless steel wire. We have the reverse labial bow, which is made up of 0.7 mm stainless steel wire. We have the fitted labial bow, which is made up of 0.7 mm stainless steel wire. Robert's retractor is the only labial bow which is made up of 0.5 mm stainless steel wire. We have the Mills retractor, which is made up of 0.7 mm stainless steel wire. And then finally we have the high labial bow, which is made up of 0.9 mm or the 19 gauge stainless steel wire. So all the labial bows are normally made up of 21 gauge wire, which is 0.7 mm stainless steel wire. It is only the Roberts retractor which is made up of 0.5 mm stainless steel wire. Now we shall go into the details of each. So a labial bow, where is it supposed to be placed on the labial surface of the maxillary incisors? It is supposed to be placed in between the middle third and the incisal third of the maxillary anteriors. This wire is then carried on to the maxillary canine, and just before the ridge of the maxillary canine, it moves vertically up. You need to take it 3 mm above the gingival margin of the maxillary canine, make it into a U shape and bring down the wire on the other side, then over the occlusal embrasure, and then the part gets into the acrylic base plate as the retentive arm. Same thing holds on the other side too. So what is a short labial bow? When you want to just retract the maxillary central and the lateral incisors. When do you use a long labial bow? When you want to retract the maxillary centrals, laterals and the canines, then we use a long labial bow. Yes, I've already mentioned to you, Robert's retractor is made up of 0.5 mm wire. Hence, this could be a little bit unstable. So we need to have a sleeve or a tubing which is placed on the distal aspect of the wire for it to give it stability. And then since you have a helix here, you have increased resiliency of the wire, and hence you give low continuous forces so that tipping can be achieved with normal frontal resorption. Then we have the Mills retraction bow, a little different modification. Purpose is the same, to retract the maxillary centrals and the lateral incisors. We have the split labial bow, which is split in the middle such that you can retract the centrals on the laterals on either side the way that you want. But this is also going to be a little bit unstable. But if the labial bow were to be split and then you see that it curves around the 2-1 on one side and the other thing curves around the 1-1 the other side. Then if you use this type of a labial bow, then you can close a maxillary median diastema too. So how is any labial bow activated? By closing the loop, the U loop. Yes, a high labial bow is called high because it is placed in the maxillary vestibule, made up of 19 gauge wire or 0.9 millimeter wire. And then from this we have the apron springs, which are made up of 0.35 to 0.4 millimeter wire, such that you can give selective pressure to one or two teeth, as the case may be, to bring about tipping of the teeth palatally. If you really want to contour the labial bow, we call it the fitted labial bow, more so given in the retention appliance. Once you have achieved what you want to achieve and you want to see to it that the teeth are held properly, then it is better that you fit the labial bow by adapting to the contours of all the teeth. The other active component of a removable orthodontic appliance would be the screws. We have the jack screws. They are known by different names: standard jack screw, a 3D screw, V screw, Bertoni, Steiner, etc., etc. So these screws are activated 1/4 turn every week, which produces 0.2 to 0.25 millimeter of tooth movement. So the force that you're producing would be 2 pounds pressure. And in a matter of 10 to 12 weeks, these screws can expand a constricted maxillary arch. But this expansion is more so dento-alveolar. So what is the screw? Any screw consists of a rod with left and right threads at both ends and a nut in the center, which is turned for activation. The threads turn in metal blocks that are embedded in the base plate, which is split at right angles to the screw. So if you want to expand a constricted maxillary arch, then you need to incorporate this screw in the middle, in the mid-palatal region, and then care should be taken to see that the base plate is also split such that when you activate the screw, then you slowly tend to expand the arch by tipping movements of the posteriors. Certain times we do have an arrow which lets us know how exactly and whether we are really activating the screw in its intended direction or not. But then you can remove this appliance, and that's the advantage of it. Activate it and then put it back. This is the way it is placed in the palate. As I said, there are different types of screws. You can bring about expansion of the constricted maxillary arch, or if you really just want to just only expand the anterior portion, well, you can do that. If you want to just move the posteriors distally, yes, you can do that. It all depends upon where you're placing the screw and how you are cutting the base plate. See, this is a sagittal screw which can be used for molar distalization. So all these tooth movements could also be achieved with a removable orthodontic appliance. And then if you really want to move a tooth, specifically buccally, the screw can be placed in such a way and the acrylic base plate can be cut in such a way that you facilitate this movement. Or sometimes you have the fan type screw where it opens up more so anteriorly rather than posteriorly. Certain times when you do encounter imbrication of the mandibular anteriors, or we call mild crowding of the mandibular anteriors, these piston screws are used which can tip the tooth labially. So these are available commercially, and then by placing it exactly opposite to the instanding central or the lateral mandibular incisor, you can tip it labially. We now come to the penultimate aspect of a removable orthodontic appliance, namely the bite planes. Why are bite planes so important? And how can they be incorporated in a removable orthodontic appliance? And what are those conditions which warrant them? We have the anterior bite plane, which is a thickened portion of the acrylic of the removable appliance. So this is used in those cases where we have a deep bite, such that when the mandibular anteriors strike on the anterior bite plane, the posterior teeth are discluded. And when the posterior teeth are discluded, they tend to supra-erupt, and in that fashion, your deep bite or your anterior deep bite is corrected. A simple appliance can correct an anterior deep bite. On the other hand, when we do not want the maxillary incisors to procline in the process of correction of the deep bite, we can extend the acrylic a millimeter or two onto the labial surfaces of the maxillary anteriors, such that the maxillary anteriors do not procline. Then we have the anterior inclined plane, which is a plane which is inclined anteriorly such that the mandibular anteriors strike it, and this helps to keep the mandible forward. This is most commonly used after the active phase of twin block therapy. If you have an anterior cross bite and you want to correct an anterior cross bite, you may be using a single cantilever or a double cantilever spring. But then in order for you to correct this cross bite, you need to relieve the bite, and hence a posterior bite plane aids in the correction of an anterior cross bite by discluding the teeth and giving enough space for the anterior cross bite to be corrected effectively. So dear viewers, with that we come to the end of part 2 of removable appliances used in orthodontics. If you would like to have a continuity of the same, please go into the link and check for the part 1, such that you have a continuity of the whole topic along with its retentive components, namely the clasps, the labial bows, the springs, as also the bite planes. So this simple removable orthodontic appliance can do a world of good for any patient if you were to take the pains to fabricate these components in an ideal way, such that you deliver optimal forces to the teeth and correct many a minor malocclusion and give the ultimate satisfaction to the patient. So thank you all for a patient listening. Thank you.